So welcome back for part 3. I was asking you this question. I was asking again regarding the information that we just went over on the side. How does measuring these distances determine the heart's rhythm? If the heart's rhythm is regular, each of these interval measurements is the same. Okay, so it's important to remember that. So analyzing the ECG strip. The ECG rhythm strip, so there's a lead to view, is evaluated from left to right. And when we're looking at the ECG strip, we're looking for rate, rhythm, the P waves. There should be one P wave before each QRS complex. Each is a positive deflection and similar in size and shape. And the intervals assess for duration and distance, appearance of the segments and waveforms. So are rhythmic PQRST cycles present? Are there any abnormalities such as more than one P wave, QRS segments without a previous P wave, or maybe an elevated ST segment? All of these abnormalities should be brought to the physician's attention immediately. Okay, abnormalities in cardiac rhythm are called arrhythmias and fall into one of 4 broad categories. So there's sinus arrhythmias, atrial arrhythmias, ventricular arrhythmias, and biochemical arrhythmias. Sinus arrhythmias, the pathway of the electrical charge is normal, but the rate or rhythm of the heartbeat is altered. Sinus arrhythmias may be caused by the SA node firing too slowly or too quickly. Atrial arrhythmias caused by faulty electrical impulses, formation or conduction defects within the atria. Premature atrial contractions, or PACs, can appear on an EKG as an abnormally shaped P wave, or there might actually be an extra P wave there. Atrial flutter occurs when the atria beat at an extremely rapid rate, up to 300 beats a minute. So when would a PAC be of concern? So occasional PACs are not abnormal, but they become a medical concern if they are regularly occurring more than 6 times a minute. Okay, so then they become a concern. We need to look closer. Atrial flutter is reversed with medication to slow the heart with a cardioversion or electrical shock. So atrial flutter is reversed when medication to slow the heart, or you can also use the cardioversion, which means you give it a shock. So here are some premature ventricular contractions in A right here. Sorry, I should show you what I'm talking about. These PVCs occur when the ventricles contract before they should for the next cardiac cycle. When do PVCs occur and how do they look on the ECG? Well, PVCs occur when an electrical change originates in either ventricle. This can appear on the ECG as an absent P wave, an abnormally shaped T wave, and a widened QRX complex. Okay, whoops, sorry, trying to fix this here. So figure B here, there are 3 PVCs in a row. Okay, so you can see that. And in figure C, so here's figure C, ventricular tachycardia, commonly referred to as VTAC, is diagnosed when the ventricles beat at an extremely rapid rate. I can't talk, I'm sorry. I think I need to pause and get some water here in a second. I'm going to go ahead and do that. So here in figure D, ventricular fibrillation. It's commonly referred to as VFib and is the most critical and life-threatening arrhythmia. It quickly results in death if not treated. So this is a big deal. And then here, what is this one? Figure E is asystole, and it is the result of the absence of a heartbeat or cardiac cessation, which shows a flat line on the ECG, which means we do not have any electrical current, and that is not a good thing. Biochemical arrhythmias. So digitalis is a common cardiac drug used to slow and strengthen the heartbeat, but too much can prove to be toxic, and it causes changes in the ECG. Potassium is a critical mineral for normal cardiac function, and too much potassium in blood or too little can both cause life-threatening arrhythmias. So how are the potassium imbalances treated? So an intravenous administration of potassium can reverse if you are needing to add the potassium. And administration of a diuretic that does not effectively spare potassium can reverse. Okay, so if you have too much. So here we see a pacemaker rhythm strip. A pacemaker is a device that's implanted under the skin that stimulates the electrical activity of the heart. The patient is instructed to telephone the physician's office periodically to transmit pacemaker readings across phone lines. Isn't that cool that we can do that without the patient even coming in? But they do this on a regular basis in order to just kind of check and make sure that the pacemaker is still working correctly. Pacemakers cause wide variations in the appearance on an ECG. So here it's showing a variation here called the pacemaker spike. So this figure, which is 2519, shows an implanted cardioverter defibrillator. And it monitors the heart rhythm and delivers shock to the heart if it detects a dangerous tachycardia or a fibrillation. So here this shows the coronary vessels. The heart muscles, the myocardium, receives its oxygen supply from a network of coronary arteries on the surface of the heart. A myocardial infarction, which we know is a what? Yes, that's a heart attack, occurs when a portion of the heart muscle becomes ischemic because the blood supplies to the area has been interrupted. Here we see the phases of the myocardial infarction, which with the electrocardiograph changes. So go ahead and take a look. This is table 25.4, and take a look at this when you're doing your notes and look at more closely the different phases and the period of ECG changes and the specific ECG changes that go with these phases. So figure 2521 shows the changes in the PQRS-T segment associated with a myocardial infarction. Again, that is a heart attack. MI causes specific recognizable changes on the ECG recording based on the phase the patient is in when the ECG is reported or recorded. So again, this goes back to looking here at our phases and then matching that here to seeing the changes in the ECG reading. So what are the three most common changes? The three most common changes are elevated ST segments, inverted upside down T waves, and abnormal pathologic Q waves. Immediate treatment for a heart attack includes administration of nasal oxygen, sublingual nitroglycerin to dilate the coronary arteries, a narcotic narcotic, analgesic to eliminate the pain, and aspirin to reduce inflammation and decrease clotting time, and possibly a thrombolytic agent to dissolve the clot causing the coronary artery obstruction. So sometimes they need to dissolve that clot as well. So a stress test. A stress test is performed to record the patient's cardiovascular response to measured exercise challenges. It's used to diagnose cardiac disease that cannot be detected by standard resting ECGs. It also is used to determine an individual's energy and performance capacity and prescribe a specially designed exercise plan. So if a patient is having some issues, if they do the stress test, they are able then to designate a specially designed program for them. Be prepared to terminate testing immediately if the patient is unable to continue or if any abnormalities appear on the monitor. Cardiac arrest is a serious risk with a cardiac stress test. So the medical assistant must be able to recognize symptoms of dyspnea, vertigo, extreme fatigue, severe arrhythmia, and other abnormal EKG readings that may develop during the stress test or immediately after the test during their rest period. Now let's talk about the Holter monitor. So the Holter monitor is a portable system for recording patients' cardiac activity over a 24-hour period, and sometimes they record it longer than that 24-hour period. Patients must keep a detailed journal of stressful events while wearing it, as well as they journal if they feel anything in episode that they noticed. You may fit the monitor on the patient, you may explain the procedures, and you may remove the monitor when working as a medical assistant. This recording is then uploaded for analysis and can be printed for further study. The electrode placement is determined by the physician or by the manufacturer's guidelines and should be followed precisely depending on what location and positioning they ask for. The skin of a male patient may need to be shaved so that the electrodes can be firmly attached because that hair gets in the way of them sticking correctly. The lead wires are attached to electrodes and then to the Holter monitor. And this Holter monitor is worn around the waist, or sometimes they use a belt or a pouch slung over the shoulder. And the patient is able to do their activities other than they are unable to shower or do anything, obviously, with water because it is electrical. Procedure 25.2 describes how to fit a patient with a Holter monitor, and we will be doing a cue card for that this week. So a cardiac event monitor. This is a recording device that can be worn for up to 30 days to catch events such as vertigo, weakness, and palpitations. Patients trigger recordings when they feel any indication of a cardiac event, and patients must be taught how to remove and reapply the electrodes to remove during bathing, because this one is 30 days, so they do need to bathe. So it's very important that their patient education is clear and they understand how to go ahead and place those correctly back after they bathe. Provide patients with details on how to conduct daily life while wearing it, because obviously if you're wearing something for 30 days, it can get in the way of certain things. So how do you think that the cardiac event monitor is different from the Holter monitor? So we know it's generally worn for a longer duration and can catch cardiac events that are difficult to record if it's just in a 24-hour period. A lot of times patients are reporting these events and then nothing's happening if they only have the Holter monitor on for the 24-hour period, but if they wear it for 30 days, they definitely can report that. Patients must not alter their lifestyle when wearing the cardiac event monitor. They need to do their regular activities, and this is because this might be, their regular activities might be a cause for their symptoms. So it's important.